Good morning. We're back today with the budget hearings. We're going to start off this morning with the Hospital Authority, and it's great to see you. Before we start, though, I just wanted to recognize that we have two council members with us joining us today. We have Council Member Erica Gilmore, and we also have Council Member Bill Pridemore, who is the budget chair for the Metro Council. So thanks to both of you all for being here today. I appreciate that. The budgets today, I think you've already talked to Talia about how we're going to run this today. It's a conversation, and Talia's going to kick us off.
Okay, good morning. Just for the listening audience, we have before us the Hospital Authority, and the Authority offers skilled nursing, rehabilitation services, and intermediate care, amongst other many valuable services to the community. They have a current Metro subsidy of $35 million and received a supplemental appropriation earlier this year for $10 million. They are budgeted for 605 FTEs, and they are requesting a flat subsidy for FY17, but there are some opportunities that Dr. Webb would like to discuss with you today, Mayor.
Great. Dr. Webb, I'm going to turn it over to you.
Okay, thank you. First, I'd like to introduce the people that are with me here.
Yes.
This is Bill Latham, our controller, and this is Mark Overlock, our legal counsel and government relations. So we have three categories that we wanted to discuss briefly today. First being accounts payable. The second category is outpatient clinics. And the third category is capital equipment and technology. Under accounts payable, the request is that we be allowed to receive funds in an amount to reduce the payables, which are currently in the amount of $7.5 million outstanding. Now, that gets us into accounts payable days that are outside industry standards, and what we'd like to do is to bring those standards back into, bring that number back into industry standards, which would get us to around 30 to 40 days. This number puts us at about 80 to 90 days. Earlier in the year, we were able to reduce that from 120 to where we are now. And so strategically, what we'd like to do is to be able to continue to reduce that number. Historically, the hospital has operated with high accounts payable days. It's just been how it's operated, and we don't have the cash flow that's strong enough to just be able to reduce it by applying a lump sum amount to it.
So explain to me a little bit more in detail. So you've got $7.5 million outstanding right now in accounts payable.
Right.
And what is the mechanism that you want to use to get that payment date down to 30 to 40 from 80 to 90?
To use a lump payment that would allow us to strategically reduce the higher days of accounts payable.
So you're asking for a supplement in addition to what we just discussed?
The 35?
Correct.
Right. Now, we can continue to operate with the high payables. It's been historically the way it's operated, and many safety net hospitals will do that. What it does, though, it allows you to really not be able to take advantage of any discount on early pay, and strategically, what it does is the vendors have become a little more aggressive with their collections. And we like to say that we're slow pay, we're not a no pay. And so the vendors have become fairly aggressive and looking for shorter time frames for their payment. And what that does is, when generally speaking all of the vendors start to do that, it puts pressure particularly on those that are more critical supplies, which we really have to make sure we put a priority on those. It starts to put pressure on that.
So if you get, if this is given as a supplement to you, how do you get those account payables to come down and be in line with industry standards? What's the mechanism that you would do?
Well, we just identify those that are in the outstanding category and go in and make the payments, go ahead and get the payments to them. And then the days this would put us within a 30-day industry.
So there are accounts payable. You owe the money.
Right.
I'm sorry, I thought you were talking about
Receivables?
yes.
No,
Yes.
payables.
Gotcha.
We owe the money.
Got it. We
So-
owe the money.
So I just wanted to, just a couple of,
$7.5 million, is that what you're asking for?
that would get us to, that would be the ultimate, that would get us to within that 30-day time frame. And there are a couple of reasons in addition. It's, generally speaking, it's costly to operate with high payables, as I said, because you don't get discounts and the penalties, late penalties can exacerbate your costs. And also, we want to be a good neighbor. We want to apply good community relations. A number of vendors that we're doing business with are local vendors, and many of them will experience cash flow challenges as well. So.
But how does this, if you go ahead and make these payments, how does that not preclude you from in 6 months needing more money? And then, again, I want to understand how this fixes it and how it changes it going forward.
The strategy is to make sure that our collections, that we're optimal in collecting as well on our payables. And that's not been in the past as aggressive as we could be.
Well, that was, I guess, my initial question.
Yeah.
What's the strategy or the
That's the
mechanism that gets you to get the money in the door so that you can, I'm not hearing the strategy.
Okay, and that's what I'm about to say.
Okay, great. Thanks.
Our accounts payables, again, when we provide a service to a patient or a population of patients, what we have to do is be very aggressive about our documentation. We have strategy in place for that. That's already operational. And in order to get the service to the point of collections, you have to be able to code it. You can't code it if it doesn't get documented. So there's a timely documentation strategy that's in place. We're monitoring that on a daily basis for our providers to do that. Once that's done, we have a coding group now that's able to code it quickly and get it up to a billing so that charges are sent out to the payers, and then the aggressiveness of collections from the billing. So that whole process has to be managed. It's called revenue cycle management, and that's what we're doing. We have a very rigorous revenue cycle management program in place to make sure that we are capturing. And the second item here will also address that, the outpatient clinic, which will take us outside of the hospital setting to have a clinic in the community that we can attract more and better payer group so that we can help to offset some of our costs that we're providing services, where we're providing services to those that don't have the ability to pay. So it will give us more diversity in our payer group as well, and that's another piece of our revenue cycle management that we're in pursuit of as a strategy. So we don't plan to just sit back and wait for this to come up again and then request another supplement. What we're trying to do is to get it within a range and keep it there.
Well, we've been trying to do that for a long time.
No, but the cash flow doesn't allow you to do that. If your cash flow is weak, you can't bring it down and you can't maintain it.
Well, which is why I'm trying to understand how the cash flow is going to be any different in 6 months or a year than it's been in the past.
By being more aggressive with collecting the bills that are due to us. And there has been, over the years, there has not been this level of aggressiveness. And so this is what we're doing. We have a specific team in place that's overseeing our revenue cycle management process and growing a payer base by providing clinic and outside of the hospital that can attract a different payer type as well.
Well, how much are clinics going to cost? Because clearly there's going to be a cost to set that up as well.
That's
so talk to me about that.
There will be a pro forma, as we're working on that as we speak, a pro forma developed to show how the clinic will generate a margin for the hospital.
And what is the estimated generation that you think that's going to be?
We're working on that. What we'd like to do is, that's the next item, what we'd like to do is to, within the next 2 weeks, we'd like to have that to the table with the pro forma and the projected capital cost for startup.
I'm less interested in the capital cost and more interested in what that's going to do for the long-term sustainability.
The outpatient clinic is one of the areas that I am going to be requesting a capital cost for, so that's why I was broaching that subject.
Okay.
So I can move on to that.
Okay, let's talk about that.
Segueing into that now.
Let's do that.
The request would be capital funds to lease and build out space for an outpatient clinic that would allow us to better serve our population and further the hospital's mission of improving health and wellness to Davidson County. That's our mission, and that would be what we would be in pursuit of with a clinic that's located away from the setting that we're in. Many would-be outpatient consumers or customers are not coming to the campus. They're seeking their care elsewhere that's closer to where they live. What we would like to do is to be able to place a clinic in more of a neutral setting that would allow that more diverse payer mix to come, and it would be in the model of a patient-centered medical home, which would allow us to be able to capture a population of patients and continue to follow them and overall improve their health care, better serving the population of Metro Nashville employees as well as others and their families as well as others in the community. This is a realistic strategy. We don't have anything outside of the campus now. Outpatient ambulatory services is where healthcare delivery is going.
And Dr. Webb, I know one of the things that I mentioned in one of the budget hearings yesterday when another department was saying, why don't we set up X? We have clinics around Nashville that provide services that are not-for-profit clinics. So I want to make sure that I understand why.
I think those are more like safety net.
Well, this is what we are.
FQHC.
These are safety net. I mean, Metro General is a safety net hospital.
Right.
So what I'm trying to understand.
This would be a product that would not necessarily be considered a safety net product. The hospital is a safety net hospital. We have 24/7 ER. We have clinics there. We have teaching clinics where the charity care is administered. We have to diversify. And this is a form of diversification where we would place a clinic in the community that would be in pursuit of a stronger payer mix and not just seeking those who necessarily don't have the ability to pay. We're going to continue to service that population, but this at least gives us an opportunity to be able to expand our service. And as long as we're providing a high-quality service and making it accessible, then we could reach out to particularly Metro employees, their families, and others. We already provide an incentive for that population to come.
But there's a
to us.
tremendous startup cost for that, and that's what I'm trying to
That's the
understand.
capital. That's the capital that I'm asking for that I'm going to have for you.
Do you have, yeah, okay. I think there were some additional projects that you had listed. Why don't we talk about those for a second?
Okay, there's just one other.
Yes.
Okay, I've got
He
several.
withdrew
You
that.
withdrew these? Okay.
withdrew those.
Okay, okay.
Okay. So just since I made these notes, I'd like to use them.
Sure.
The clinic would basically improve access to that equitable coordinated care that we talk about in our mission statement. We do not have the capacity on our campus to service the needs of this outpatient population, so this would allow us to have better capacity and to grow the payer mix. And it would also help to offset the operating costs of the hospital and make us more fiscally sustainable going forward. And it would also, as I said earlier, better serve the Metro employees and their families with accessible care to that population. Now, the last item here is capital equipment and technology needs. Capital funds to update the age of the plant, the hospital, the general hospital, by investing in state-of-the-art medical equipment technology in areas where those needs are indicated. As a teaching hospital for Meharry Medical College, this will also assist with the recruitment of medical providers, employees, researchers, and medical students. It will also allow Nashville General and Meharry providers to take advantage of operational efficiencies and clinical processes that are available by the newer technology. This will also allow us to take advantage of opportunities of state-of-the-art technology that would allow us to improve and provide a safer environment for the patients that we serve. Not that we don't have a safe environment, but there are always opportunities to improve on your safety in your environment. We drive safe cars, but technology is always there to make them safer. So that's what we'd like to take advantage of as well. And,
So give me an example of what kind of capital investment on technology equipment that you're asking for.
You know, there's imaging equipment that's constantly changing, and that allows you to see more, to be able to, for the physicians to be able to do better diagnostics, locating disease patterns, and, for instance, the CAT scans, the nuclear accelerators. We have those forms of technology, but the generations move forward pretty quickly. What we want to do is to be able to assess, using our medical partners at Meharry, assess our needs and to make sure that we have a strategy for staying within a certain range of technology in providing care to our patients. We don't want that to be a barrier for the growth of either one of the organizations, or to be a barrier to our patient populations receiving optimal care in the community. So there is a community standard that you just don't want to fall outside of if you're going to be a provider in that area.
Okay. Anything else on that?
That's it.
Great.
Both of these two items, what I would like to do is to get some information back to you. We're working on that now. We'd like to, within a 2-week period, we'd like to get back to you with what that looks like.
Absolutely. And I also just want to recognize that Council Lady Sharon Hurt has joined us. It's good to see you. Good morning. Okay, so we'll wait on those estimates and cost factors. Talia.
Yes, would you discuss just briefly your revenue projections from non-metro resources for the next budget cycle?
Yes. We typically collect, 43 million over the course of a year from our collections. We have the essential funds, state, federal funds that will come in matching in the form of net 10 million. We match a $6 million with that, and then there's an additional $2 million DISH funding that we receive. I believe that those are the sources of our revenues. We do plan to, with our more aggressive pursuit of revenue cycle management and enhanced payer class of patients, we do plan to enhance that the revenue or the net revenues that we generate.
It appears on your sheet that you're showing about 8.3% growth in patient revenues for next year. You feel like that's realistic?
Yes.
Okay.
Revenues are down $2 million from 15. Right? You're down $2 million this year from where you were in 15. So, I mean, aren't you seeing less patients, less clinic visits, and less inpatient?
No, actually, what's happened is the length of stay for each patient, and when you're taking care of individuals that have limited ability to pay, length of stay is a very critical measure that you want to manage, and you want to get it as low as you possibly can. If you'll notice, our average daily census did not drop, but yet well, it might have dropped minimally, but our length of stay, the amount of time that each patient stays in the hospital, which each extra day a patient stays in the hospital is an extra cost to us. So actually, it's about how well you're collecting more so than what your gross revenues are, because gross revenues can be misleading in healthcare, particularly. You see the level of contractuals.
Yeah, so I was looking at net patient revenue. Net patient revenue is down $2.5 million projected this year over last year. But yet you think you're going to gain $6 million next year.
Well, and that has to do also with our ability to collect.
And that goes back, though, to a more expansive
Aggressive.
payer mix.
And more aggressive revenue cycle management.
Right. Which I'm still trying to get my arms around, this idea that if your patient population can't pay to begin with, how being more aggressive gets more dollars in the door.
Because you have a portion of that population that does pay.
$6 million worth?
It's not, do we have $6 million worth?
Well, that's
I'm sure we
the
should.
projected revenues.
Yeah, we should be able to do that.
Okay. And going back to the trends, I just want to make sure I'm reading this right. So I've got patient days from 2014 at 17,000, from 2015, 16,000. So those are trending down. So you're saying that it's better to get the patient days down because it's...
What you want are admissions and discharges. You want your discharges up, but your patient days, you don't necessarily need large patient days. Your length of stay represents cost, and you want a shorter length of stay so you can keep your costs down, but keep your volume up.
Okay.
What about on the clinic side, though? Are you seeing decline in clinic visits?
So that was due to a limited provider availability by our medical providers. We're working with Meharry now to get that number of physicians, to get more physicians to be able to keep our clinics open 5 days a week. We also want to look at weekends and after hours for our clinics.
But you want to also establish another clinic. So how's that one going to get staffed?
Well, we're gonna have a combination of, we might have to utilize our own physician resources to come in to supplement the Meharry physicians. It depends on whether they're going to be able to accommodate at that level or not. We've had that conversation as well. And we're also looking at opportunities for recruitment if necessary.
So the new clinic, the proposed clinic, how does that work, or does it, like with Matthew Walker or something like that? Why Matthew Walker's in that business, and why are they serving a different audience, or should we be working with them to try to attract that audience?
The short answer to that question is yes, they are. They're federally qualified their safety net clinic. This won't necessarily be a safety net clinic, even though it will not turn away individuals that won't have the ability to pay. On our campus, we have our teaching clinics, which is basically where we pay Meharry providers through our PSA to care for that population. We will make an attempt to diversify our payer population, which we will have physicians available to take care of all populations, but it will be in an area where the likely group that will be in attendance at those clinics will be a more diversified payer group.
And all this plan is contingent upon an additional $7.5 million to clean up the receivables.
Plus
No.
the whole capital investment.
No, it's not dependent upon the AP.
Spending on capital.
Capital and
Yeah,
operating.
it's more the capital than the AP. The AP is strategically an area that we want to get under control because
7.5 is just to put you in line with industry standards for payables. And then the hope is that you would create a clinic that would somehow come up with a payer mix that would then generate more money so that you would be in line with being able to pay your bills, right?
yeah,
Okay.
I usually don't look at hope as a strategy, but it's what we plan to do.
Okay. Well, I need more information, and I think you've got that request in for 2 more weeks to go back out with to give us additional dollar figures. Talia. Anything else?
No, I think I'm good.
You're good, Rich?
I think I asked you this before, and I can't help myself but ask again. The $7.5 million gets you to 30 days, just for clarification, or it cleans up every bill that you're owed, that's owed out there? And I was a little confused about that before, about
Because
the
there are,
7.5.
and I'm sure the controller can explain it
Yes.
better, but because there are constantly bills bills coming in
Yes.
that are being invoiced. You know, there are outstanding ones probably that haven't even been invoiced. These are the ones that we know of that have been invoiced, and so this is what's there. If we pay this, at max, you will be looking at a rolling uninvoiced amount of, say, 30 days. That's just industry standard. I mean, that's low industry standard there. What we're trying to do is what we have invoiced that we know is out there, we want to get that down, get those taken care of, and then we're operating within a normal range.
And then the supplemental, we just provided,
That got
how
us
much of
from
that was
120.
about 2 million of that was used for AP?
That was 3.
It was 3? So we had about 10 million total
This
that
one,
we're
yeah.
dealing with on the AP
Doing the
side?
math, yes.
Okay,
But that doesn't include the
yes,
normal subsidy that we already
Right.
give, the 35 million.
No,
right, okay.
which we're not asking for anything in addition to that, but the payable.
Except that was-
is-
You're asking for a one-time
The original
kind of infusion
Right.
to clear out the pay, to
And
clear out the
that's a good
AP.
point, because as I said earlier, the cash flow just doesn't get strong enough for you to meet your payables, meet your payroll, all of the things you need to do, and infuse that bolus of capital to bring it down to where you can start to operate within that range.
Well, and the $35 million supplement, I know that Metro Council has given over time, was, the plan was to actually reduce that because of some changes to Bordeaux and to Knowles, but I'm understanding that you want to keep that subsidy the same. Is that correct?
Yeah, that's been the plan all along, to maintain that 35. But we didn't increase that.
Well, actually, it was supposed to reduce because of the Bordeaux and the Knowles component.
Wasn't it higher with the,
At one time.
At one time, but the whole point was to bring it down.
right, to
I mean,
35?
we've had conversations before, Dr. Bub, where you said you thought that subsidy could go down. I mean,
35. I mean, over time, I believe it can go down from that.
yeah, well, it's
Yeah.
different from what you said a year ago or 6 months ago, but that's okay.
That's okay. We're moving through it. Okay, all right. Anything else?
I am good.
I'm good. I just also want to recognize that Councilmember Larry Hager has joined us in the back. Thank you, Larry, for being here. All right, any other things? We'll just wait for the rest of that information in the next 2 weeks so that we can see what the plan looks like. I appreciate it. Thank you all for being here. Thank you so much. Thanks.
Thank you, Lauren.